Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my clinical biochemistry playlist, which is all about clinical diseases, not just basic biochemistry mumbo jumbo. In previous videos, we talked about glycogen storage diseases, lactose intolerance, galactosemia, sorbitol and cataracts, insulinoma, glucagonoma, somatostatinoma, gastrinoma, and even vipoma. Then we talked about cystinuria, cystinosis, and homocystinuria versus Marfan syndrome. And then we talked about Marfan syndrome versus Ehlers-Danlos syndrome. Don't forget osteogenesis imperfecta. Now, pyruvate kinase deficiency. Normally, pyruvate kinase exists in glycolysis pathway. Important to make ATP, which is energy. Without ATP, the ionic pumps of my red blood cells will fail. Water rushes into the cell swells, the membrane gets weaker, pew! It ruptures. When many red blood cells rupture, I get hemolysis, hemolytic anemia, and unconjugated hyperbilirubinemia, which causes jaundice, which is defined as yellowish discoloration of skin, mucous membrane, and sclera. Please watch the videos in this clinical biochemistry playlist in order. Pyruvate kinase deficiency is an autosomal recessive disease. Remember when I told you, if a disease is autosomal recessive, two things have to be remembered. Number one, consanguinity is usually a culprit. People who marry one of their relatives in a tight-knit community. Fact number two, many autosomal recessive diseases have enzyme deficiencies. Case in point, pyruvate kinase deficiency. Why do we need pyruvate kinase? Back to basics, your diet is either carbs, proteins, or fat. Break down the carbohydrates. What do you call that? This is called digestion, until you give me the doozy monosaccharide called glucose. Why is glucose so important? Because it has 6 carbons. Carbons are not very electronegative, which means here is the nucleus of carbon, and then we have the electron shells. The electrons of carbon are far away from the nucleus, which means less electronegative. When an electron is far away from the nucleus, it occupies a high energy shell. High energy, high energy, high energy. Oh, we can give that electron to an electron acceptor, like NAD plus or FAD, or the final electron acceptor, Mr. Oxygen. That's why we call it cellular respiration. And when you give these electrons to oxygen, who is the final electron acceptor, you are giving energy. Exergonic reaction. Energy is extruded. This is how you function as a human being. So let's go. Glucose to pyruvate, glycolysis. And then throughout many steps, you make even more ATP. This is called the tricarboxylic acid cycle or Krebs cycle, followed by the electron transport chain. These last two processes happen in the mitochondria under aerobic conditions. Question. Does your red blood cell have a mitochondria? No. Do you think the red blood cell can perform the TCA cycle or the electron transport chain? No. Therefore, the only hope for your red blood cells to get some energy is through glycolysis, which does not require oxygen. But hey, Medicosis, this will yield me only 2 ATP molecules, not 2 dozens or so. Well, better than nothing. But if this red blood cell lacks an important enzyme here known as pyruvate kinase, do you think the red blood cell will be able to make energy? No. Without energy, what's going to happen? The red blood cell is toast. It will die. Why did the red blood cell lose the mitochondria? Because I know that the red blood cell precursors had mitochondria. What happened then? Well. Remember that the most important function of your red blood cell is to give oxygen to other tissues, which means this oxygen molecule has to occupy some space on the hemoglobin. And the hemoglobin itself has to occupy some space. And since we live in a world of limited resources which have alternative uses, we have to economize. That's why the red blood cell sacrificed herself for others and said goodbye to her mitochondria. Another key reason is that if you leave the mature red blood cell with a mitochondria, the red blood cell will consume the oxygen in the red blood cell itself through TCA cycle and electron transport chain, and therefore there will be no remaining oxygen available for the rest of the tissues like your brain. We call this an ischemic stroke. Not enough oxygen for your heart. We call this myocardial infarction. Not enough oxygen to your liver. We call this ischemic hepatitis. Not enough oxygen for your gallbladder. We call this a calculus cholecystitis. Not enough oxygen for your kidneys. Pre-renal azotemia, or worse, ischemic acute tubular necrosis. Not enough oxygen to your extremities. Acute limb ischemia. See, medicine makes so much sense once you understand what the flip you're talking about. So the only hope for the poor red blood cell is glycolysis. I hope that you watched my videos on glycolysis in this biochemistry playlist before watching today's video. Glycolysis is converting glucose to pyruvate. Is this just one step? No, many steps. Glucose enters into the cell, okay? Why not just leave it as glucose? Because it can just go out of the cell again, which is pointless. What's the point of getting glucose in so that it can leave me and go out again? Oh, what do you do then? I have to fix it inside the cell. How do you fix stuff? Phosphorylate it. Phosphorylation fixes stuff because the door of the cell can recognize glucose and open that door, but the door can never recognize glucose 6-phosphate, which means the door will not open. What's the name of that door? GLUT, glucose transporter. Okay, and then I have glucose 6-phosphate. Let me just burn this and bring some energy out. If you do this, it will be an explosion. You will have no control over the reaction. Okay, I do not want this. I want to have some control. Therefore, you need to convert that glucose into fructose. It's isomer, because you can have more control over that isomer. Okay, I'll use an isomerase then. And that's why in the first steps in glycolysis, we're actually sacrificing our own energy so that the reaction can go through in a controlled fashion. Because think about it, glycolysis is supposed to give you ATP, not take some ATP from you. So why are we doing this? So that we can have more control. Okay, now I have fructose 6-phosphate instead of its isomer, glucose 6-phosphate. Now what? Now we need the key enzyme, the key rate limiting enzyme. Who's that? Phosphofructokinase. What does a kinase do? Usually adds a phosphate. When you add a phosphate to the fructose 6-phosphate, at carbon number 1, what would you call this? Fructose 1 and 6 2 bi or bisphosphate. Then this fructose 1 and 6 bisphosphate becometh glyceraldehyde 3-phosphate and DHAP. This molecule used to have 6 carbon atoms, but it will give you 2 molecules. Each one has only 3 carbon atoms. And then you keep going down several steps. You end up with phosphoenolpyruvate. Let me tell you something important. Suppose that A, by using enzyme B, will become product C. If I have a deficiency in enzyme B, anything before it will accumulate and go up, and anything after it will not happen at all. It will decrease. Similarly, if I have a problem in pyruvate kinase right here, everything before it will go up. So I'll get elevated levels of phosphoenolpyruvate, increased level of 2-phosphoglycerate, etc., until you end up here. And this guy can become what? 2,3-BPG, the famous one that shifts the oxygen hemoglobin dissociation curve to the right. Remember that in literature, the right hand symbolizes giving instead of taking. Giving of what? Giving oxygen. Giving oxygen to whom? To the tissue, which means the hemoglobin on the red blood cell will give the oxygen to the tissue, which ameliorates the symptoms of anemia. That's why patients with pyruvate kinase deficiency usually have mild symptoms. Conversely, patients of the less common pyruvate dehydrogenase deficiency have more severe, if not fatal, symptoms, for reasons that we'll elaborate in the next video titled Pyruvate Dehydrogenase Deficiency. The phosphoenolpyruvate, to be converted into pyruvate, needs the enzyme, the hero of today's story, pyruvate kinase. This actually gives us energy. Woohoo! That's an amazing enzyme. So pyruvate kinase normally converts phosphoenolpyruvate into pyruvate inside the pathway of glycolysis. Does it have to have oxygen? No, if you have oxygen or if you lack oxygen, we can work either way. That's amazing, and this pyruvate kinase will add a phosphate to adenosine diphosphate so that it become adenosine triphosphate, the energy currency of the cell. Now think of your poor red blood cell without pyruvate kinase. Do you think the red blood cell will produce enough energy? No. Disease, pyruvate kinase deficiency. What's the problem? A defect or deficiency in pyruvate kinase enzyme. Why? Usually a genetic disease, genetic cause, inborn cause, inherited in an autosomal recessive fashion. Consanguinity and enzyme deficiency. Actions have consequences, and so do deficiencies. This enzyme, may he rest in peace, was part of glycolysis. Say goodbye to glycolysis, which means say goodbye to anything that comes after glycolysis. But since we're just focused on the red blood cell mainly in this condition, let's just imagine that for whatever reason, we're not having enough ATP. But of course, in other tissues, it will be lack of glycolysis, and therefore problem in the TCA, and therefore not enough electron, etc., which means not enough energy. Okay, who needs energy? The active pumps in your cells, including the sodium-potassium pump. Where can I find the sodium-potassium pump? In every single stinking cell in your body, including my red blood cell? Yeah, why not? And if you have watched my videos in my fluids, electrolytes, and acid-base disturbance playlist, I've told you about the consequences of having a sodium-potassium pump. This pump is so dear to my heart, you have no idea how important that is. It regulates electrolytes. Who follows electrolytes? Water. Oh, no ATP equals no sodium-potassium ATPase pump because it needs energy, and you have no energy, which means you have an electrolyte disturbance. Your ions are disordered. Who follows electrolytes? Water. My red blood cell will become dehydrated. Oh, who's gonna suffer? The membrane, the cell membrane. The good old phospholipid bilayer? Indeed. Damage of the membrane of the red blood cell will make them look like this. We call these Burr cells or echinocytes. Cyte mean cell. Echino means like a hedgehog. Some spikes action. Okay, when the red blood cell is horrible like this, what's going to happen? It will rupture. Hemolysis. What's the purpose of the red blood cell? To provide your tissues with oxygen. Say goodbye to that. You get anemia. Hemolytic anemia is usually normocytic and normochromic. Symptoms of anemia. No oxygen. I'm tired and pale. I am pale and tired. Sometimes I have angina. Sometimes I get a murmur. It's a systolic flow murmur, in case you're wondering. Typically heard in the second intercostal space. Other symptoms of anemia include dizziness, drowsiness, dyspnea, exercise intolerance, and much more. Is that it? No. When the red blood cell is destroyed, the red blood cell is gonna give us whatever was inside, which is Mr. Hemoglobin. I love the name hemoglobin, which is made of heme and globin. All of this is coming out of the red blood cell right now. Globin is a protein made of a bunch of amino acids that your body can recycle. Okay, no big deal. But heme is the big deal because heme will be broken down into iron and protoporphyrin. Okay, and then what? Protoporphyrin will become a green substance known as biliverdin. The word verd or vert means green. And then the biliverdin will become bilirubin. Before the liver, bilirubin is called unconjugated bilirubin. The unconjugated is insoluble in water, which means your kidney will never be able to excrete it. Therefore what? Therefore you have to change it into something water soluble. How can I do this? By conjugation. Oh, so you conjugate your unconjugated bilirubin so that it becometh conjugated bilirubin. The conjugated bilirubin is water soluble. The liver will send it to the kidney will excrete it into the urine. Remember what we have just said. If A, by enzyme B, gives me product C, and B is toast as an enzyme, anything before it will go up, anything after it will go down, which means what was before pyruvate kinase, please? Oh, the 1,3 and 2,3 BPG and all of these lovely people? Yes, indeed. Right shift of the oxygen hemoglobin dissociation curve. When you shift to the right, you are giving that oxygen to the tissue, which alleviates and ameliorates the symptoms of anemia. Patients with pyruvate kinase deficiency might suffer from intravascular hemolysis or extravascular hemolysis, mostly extravascular, but it could go either way. Recall that the red blood cells are here. These are the mature red blood cells. Before them, what are the names of the baby red blood cells? Reticulocytes. Hemolytic anemia is usually normocytic, normochromic, which means the MCV level is usually normal, between 80 and 100 femtoliters. Can you give me some causes of anemia? Yeah, maybe you're losing blood, or maybe you're not making enough red blood cells, or maybe you have enough red blood cells, but you're destroying them, as in cases of pyruvate kinase deficiency. Why am I destroying my red blood cells? Is it because of something in them or something outside of them? It's because of an intrinsic defect, an intrinsic enzyme deficiency known as pyruvate kinase deficiency. Hemolysis could be intravascular or extravascular. What do you mean by extravascular? Outside the vessel. Like, where are you talking about? I'm talking mainly about the spleen and other organs of the reticuloendothelial system. Tell me how this extravascular hemolysis happened. The spleen is very brilliant. It can recognize the defects in your red blood cells. Sometimes there are inclusions, sometimes there are antibodies attacking the red blood cells, sometimes there is a missing enzyme, sometimes there is a weird red blood cell that looks like a hedgehog, like a burr cell, a kinocyte. Regardless, the spleen will say, this abnormally shaped red blood cell or this abnormal red blood cell has to go. I will destroy it. How would you destroy it? I have my macrophages, known as the splenic macrophages. Macrophages will break down the red blood cells. Phew! This is called hemolysis. Anytime you break down red blood cell, hemoglobin comes out. Hemoglobin is made of heme and globin. Heme is made of iron and protoporphyrin. Protoporphyrin becometh biliverdin, which becometh unconjugated bilirubin, not water-soluble. Then the liver will conjugate it into conjugated bilirubin, which is water-soluble. Anytime you destroy a cell, such as a red blood cell, whatever enzyme was inside, whatever protein was inside, will come out, such as lactate dehydrogenase. So in cases of hemolysis, we see elevated levels of lactate dehydrogenase in the plasma of the patient. Moreover, when you have lots of hemoglobin floating around freely outside the membrane-bound red blood cell, a sponge has to come and clean all of that hemoglobin. Otherwise, it will damage your kidney tubules. What's the name of that sponge? Haptoglobin. Haptoglobin will bind that hemoglobin and take good care of it. So what do you think is going to happen to your sponges? I'll start consuming my sponges. So the haptoglobin level goes down. This is largely a controlled process happening in an organ that is an expert at destroying cells. And that's why the kidney is still fine. It's true that this unconjugated bilirubin can give me pigmented gallstones, but the kidney is fine. In most cases, that's the extravascular, i.e. intrasplenic hemolysis. Next, intravascular hemolysis. Oh, it just happened inside the vessel. Oopsie, there was no professional spleen to take care of the problem. Yeah, all of that hemoglobin ends up in your blood. Whatever is in your blood is going to end up in the kidney. Hemoglobin and the hemosiderin that comes from hemoglobin are very, very, very toxic to your kidney tubules. And they can show up in the urine. Hemoglobin, urea. Hemosiderin, urea. What does hemo mean? Blood. What does sidero mean? Iron. Does anyone remember hemosiderosis? Sideroblastic anemia, where we have iron constellations inside your red blood cell? Can these babies have black stool called melena? The answer is yes, because don't forget, you have vessels in your gastrointestinal tract. Clinical symptoms of hemolytic anemia are the same signs and symptoms of any anemia. I'm tired and pale, pale and tired. Sometimes I have angina, sometimes I have a murmur, exercise intolerance, dyspnea, dizziness, etc. And don't forget, this unconjugated hyperbilirubinemia will give me jaundice, yellowish discoloration of the skin and sclera. If the spleen is working too hard, I can get splenomegaly. Other reticuloendothelial organs include the liver, hepatomegaly. Take me to the lab. What should I order? Complete blood count. Okay, all right, let me look at the red blood cells. What do you think happened to my red blood cell count? Well, it's usually low if it's a chronic hemolysis. How about hemoglobin concentration? Low. hematocrit value or packed red cell volume, low, reticulocyte count. Oh, this is important. When you start losing mature red blood cells because you have hemolysis, the bone marrow, as long as it's healthy, will respond and say, quote, "What's going on over here? Every time I make mature red blood cells, they get destroyed outside of me. Therefore, I'll need to make more because I am a good guy." So the bone marrow will start making more red blood cells, more red blood cells, more red blood cells, and more baby red blood cells. And sometimes the bone marrow, because it's rushing itself and working overtime, doesn't pay attention and will give us immature red blood cells instead of mature ones. What's the name of the immature ones? Reticulocytes. So the reticulocyte count goes up. Okay, what kind of anemia is hemolytic anemia? Normocytic, normochromic, so the MCV, mean corpuscular volume, is about normal, which is between 80 and 100. But hey, medicosis, my textbook says 76 until 96. Who gives a rip? Doesn't matter that much. Anytime you break down a cell, like a red blood cell, whatever enzyme was in will go to the outside. Lactate dehydrogenase goes up. But you consume all of your sponges. Haptoglobin goes down. Anytime you break down hemoglobin, what do you get? Heme and globin. Heme is made of iron and protoporphyrin. The protoporphyrin will become biliverdin, which will become unconjugated bilirubin, and it will go up. Unconjugated hyperbilirubinemia, which contributes to jaundice. Coombs test should be negative in pyruvate kinase deficiency. So why are you ordering it? To rule out autoimmune hemolytic anemia. Next, give me a peripheral blood smear or peripheral blood film. Look in the blood. Oh, you will see these weird looking red blood cells known as Burr cells or echinocytes. Next, you can confirm the diagnosis of pyruvate kinase deficiency by measuring the enzyme assay in the red blood cell. Look, Burr cells, echinocytes, like a hedgehog. Not every Burr cell is pyruvate kinase deficiency. Not every echinocyte is hemolysis. It could simply be an artifact due to ADTA, which is used in the purple top test tube that we use in the lab, that we use to collect the blood. Uremia can do it, hypophosphatemia, hypomagnesemia, hemolytic anemia, marathon runners. These are called what? Echinocytes. Do not confuse echinocytes with acanthocytes. I have a separate video on acanthocytes. Let's summarize everything about pyruvate kinase deficiency in one slide. The problem is a deficiency of pyruvate kinase enzyme. Who's going to suffer the most? The cell that is the most dependent on glycolysis, which is the red blood cell. Dehydrated red blood cell, damage to the membrane, echinocyte, rupture, hemolysis, hemolytic anemia, which is normocytic, and hemolytic jaundice, which is unconjugated hyperbilirubinemia. Thankfully, when the enzyme is toast, everything before it goes up, so increase 2 and 3-bisphosphoglycerate shifts the oxygen hemoglobin dissociation curve to the right. You give more oxygen to the tissue and decrease the severity of the anemia. Signs and symptoms or history and physical exam: tired and pale, pale and tired, exercise intolerant, and jaundice, and sometimes black tarry stool / melena. How can I diagnose it? Complete blood count, hemoglobin, hematocrit, reticulocyte count, MCV level, LDH level, unconjugated bilirubin level, haptoglobin level. Peripheral blood smear, red blood cell enzyme assay for pyruvate kinase enzyme to confirm its deficiency, and we can do genetic studies because this is an autosomal recessive disease. Management depends on the severity. Most patients have mild symptoms, so just conservative preventative therapy. Make sure that these patients, if they have anemia, are not iron deficient, because that's a very common cause of anemia. We do not want to make the anemia worse. So lots of iron. You need to eat diet that is rich in iron. If that's not enough, iron supplements, which can change the color of the stool and sometimes cause constipation. If the anemia is so severe and the hemoglobin and hematocrit are so low, give red blood cells. Blood transfusion. For some enzyme deficiency diseases, not all, enzyme replacement therapy is available. They make this enzyme via recombinant DNA technology, and sometimes when you give the patient the missing enzyme, the patient's symptoms improve. If the anemia is so bad and it failed every treatment and the splenomegaly is so severe and the symptoms are horrible, after waiting and contemplating, sometimes it's a good idea as a last resort to remove the spleen. This will remove the organ of destruction, which is causing most of the hemolysis. But you should not just remove the spleen willy-nilly, because it's an important immune organ, without which I suffer from bacterial infections. And that's why many patients during splenectomy procedures require vaccines and antibiotics, because you're removing an important immune organ. You can learn about the antibacterial medications, antivirals, antifungals, and antiparasitic ones by downloading my antibiotics course at medicosisperfectionalis.com. What else can lead to hemolytic disease of the newborn? Rh incompatibility, isoimmunization. When mommy is Rh negative, her husband is Rh positive, and the baby is like his daddy, like father, like son. I'm also positive, but mommy hates the daddy and therefore is gonna hate the newborn. It's gonna attack her baby. Immunologically speaking, just in case there are freaking lawyers watching. If you do not want to download my courses but would rather watch them right here on YouTube, click the join button, choose the highest tier to gain instant access to more than 300 premium videos right now. Please subscribe, hit the bell, smash like, support my channel here or here. Go to my website to download my courses, notes, and cases. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.